Okay, so we are now discussing endocrinology. So first, a patient has the following thyroid profile. So total T4 here is decreased. T4 is decreased, thyroid peroxidase antibody is positive, and decreased thyroid stimulating hormone. So again, for here, important po na alam natin how to differentiate primary, secondary, and subclinical condition. So for primary nga po, ibig sabihin the problem is in the target gland itself, wherein in this case nga the thyroid gland, while for secondary the problem is in the pituitary gland, okay, in particular in the anterior pituitary, and then for tertiary, the problem po is in the hypothalamus. For dito naman, we don't need to differentiate naman primary, secondary here, but for this case, there is decreased TSH, decreased T4. So again, a case of secondary hypothyroidism, or simply in the given choices, we have hypothyroidism. Okay. Next, a 45-year-old woman complains of fatigue, heat intolerance, and hair loss. Total and free T4 are abnormally low. If the TSH showed marked elevation, this would be consistent with okay, so low T3, low T4, and then the TSH is showed marked elevation. So this one is a case of primary hypothyroidism. Okay, so we have letter D, primary hypothyroidism. Again, no, for the thyroid function test, the TSH test serves as the most informative laboratory test. It is the most important thyroid function test to differentiate nga po primary, secondary, and subclinical conditions. Okay. Um, so yun, no? We have here a 45-year-old woman complains of fatigue, cold intolerance, and hair loss. Okay. So let me correct this one. This one should be cold intolerance for characteristic for primary hypothyroidism. Okay. Next po tayo. A 68-year-old female patient tells her physician of being cold all the time and recent weight gain with no change in diet. The doctor orders a TSH level and the laboratory reports a value of 8.7 where the reference value is 0.5 to 5. So in here there is increase in the TSH value, and the characteristic clinical manifestation of the patient here shows that there is a weight gain. So kahit na wala naman change sa kanyang diet, the patient is have a low metabolism, hence resulting to a weight gain, which is characteristic nga po for primary hypothyroidism. Okay, so primary hypothyroidism. So again, since thyroid hormones is important for the body metabolism, so low T3 and low T4 will be characterized by a low body metabolism. It will also show signs and symptoms such as bradycardia, weight gain, and cold intolerance, as well as mental dullness. On the other hand naman, kapag there is a primary hyperthyroidism or Graves' disease, there is a case naman po of tachycardia, weight loss, and heat intolerance. So mabilis naman yung kanyang body metabolism. So kahit na kain siya ng kain, still the patient will still lose weight because of a high metabolism. So ganun naman kapag case ng hyperthyroidism. Okay, again, kapag subclinical condition naman po, kapag subclinical walang signs and symptoms, the T3 and T4 are normal, but the TSH level is already showing abnormal results. For example, in case of subclinical hyperthyroidism, normal T3, normal T4, pero decrease na ang TSH. So malapit na siyang mag-lead to primary hyperthyroidism. Kapag subclinical hypothyroidism naman, normal T3, normal T4, pero increase na ang TSH. So malapit na siyang progress to primary hypothyroidism. Okay? Next, which of the following steroids is an adrenal cortical hormone? So we have here the aldosterone. Okay? So another kasi kung sa endocrinology part, no, majority that will be asked would be involving the thyroid hormones, and the other naman involving the hormones in the adrenal gland. No? So adrenal gland is composed basically of the adrenal cortex and the adrenal medulla, wherein the adrenal medulla is the one responsible for the production of catecholamines, particularly your epinephrine or epinephrine. No? But for the adrenal cortex, the adrenal cortex is divided into three layers, as what you can recall. We have the zona glomerulosa, producing the mineralocorticoid aldosterone, which is the answer here, letter B, aldosterone. We also have zona fasciculata that produces cortisol, and zona reticularis that produces the weak androgens. Okay? So, in this case nga po, we have your aldosterone produced by the zona glomerulosa. Take note as well of the role of the aldosterone. Aldosterone promotes sodium reabsorption and potassium excretion. Okay? Next po tayo, we have your adrenal Cushing's syndrome. So, for Cushing's naman po, there is a characteristic hypercortisolism. And to differentiate nga po Cushing's syndrome from Cushing's disease, kapag Cushing's syndrome, the problem is in the adrenal gland itself. So, pwedeng may case ng adrenal adenoma resulting to adrenal Cushing's or Cushing's syndrome, resulting to hypercortisolism. While kapag Cushing's disease naman po, this one is the pituitary Cushing's naman, wherein there is increase in the production of the adrenocorticotropic hormone, hence increase ng cortisol production. Okay, pero sa case po ng Cushing's syndrome or adrenal Cushing's, mataas po ang production ng cortisol, pero as a part of negative feedback mechanism, mababa ang production ng ACTH. Kasi po dito ang problem naman ay nasa adrenal gland itself, no, or nasa adrenal cortex. No? Kaya dahil po doon mataas ang production ng cortisol, pero negative feedback po doon, mababa ang production ng ACTH. So we have letter B. ACTH is decreased, cortisol is increased. Kapag yan naman po ay a case of secondary hypercortisolism or sa case ng pituitary Cushing or Cushing's disease, the cortisol is increased because of increase in ACTH. The problem is in the pituitary gland producing high amount or secreting high amount of adrenocorticotropic hormone, thus stimulating the adrenal cortex to produce more cortisol. So yung letter A po dito is the case naman po kapag kapag secondary hypercortisolism or Cushing's disease or pituitary Cushing. While for letter B, yung answer po natin dito is for your Cushing's syndrome or your adrenal Cushing's or your primary hypercortisolism. Okay? Next po tayo. Also take note that increase in blood glucose level in the body or in the blood is not only because of diabetes mellitus. No? So we have many hormonal problems as well that can result nga po to hyperglycemia, such as a case nga rin po ng Cushing's syndrome, wherein there is increase in cortisol. And as we know, cortisol is also a hyperglycemic hormone that promotes gluconeogenesis or the conversion of other sources, such as your lipids, proteins to glucose. So there is also a characteristic hyperglycemia among patients with Cushing's. Okay, in here, I have here a table. I made here a table differentiating yung Cushing's syndrome, Cushing's disease, and ectopic ACTH production. So pag a Cushing's syndrome, again, the problem is in the adrenal gland itself. Like for example, pag may case ng adrenal adenoma, resulting to high amount nga po of cortisol. Pero dito, mababa ang production ng ACTH as part of negative feedback. Sa case naman po ng Cushing's disease or pituitary Cushing, the problem is in the pituitary gland itself because of a pituitary tumor resulting to increase in the production of ACTH dahil po doon magkakaroon ng increase ng production ng cortisol ng adrenal cortex. Sa case naman po ng ectopic ACTH production, ibig sabihin, nagkaroon po dito ng production ng adrenocorticotropic hormone because of tumor, not in the pituitary, not in the adrenal gland pero other tumors that is producing the adrenocorticotrophic hormone. So dito mataas nga po ang ACTH, mataas din ang cortisol. So para din po siyang um, pituitary Cushing, no, sa Cushing's disease. But the difference here is the dexamethasone test. We know that dexamethasone is a screening test, no, for your hypercortisolism, wherein dexamethasone is known to suppress cortisol. Okay? So, it is used to suppress cortisol. Pero pag may case po ng Cushing syndrome, this one will not be suppressed. So, ibig sabihin kapag hindi siya na-suppress, even after administering dexamethasone, mataas pa rin ang level ng cortisol kasi nga hindi siya na-suppress ng dexamethasone. Pero pag may case po ng Cushing's disease, no, this one will be suppressed. No? So dexamethasone will suppress the adrenocorticotrophic hormone, hence resulting to decrease in the cortisol. So after administering dexamethasone, mag-normal na yung level ng cortisol kapag case ng Cushing's disease. No? And then kapag case naman po ng ectopic ACTH production naman, no, in comparison to the Cushing's disease, kasi pareho silang mataas ang ACTH dito, resulting to hypercortisolism, increase in cortisol, no? Pero one of their main difference is the dexamethasone. Kasi sa Cushing's disease, pituitary Cushing, this one will be suppressed, while for ectopic ACTH production, it will not be suppressed. Pag sabi hindi suppressed, ibig sabihin, the cortisol levels remains elevated. Okay? So, in the given problem here, increase ang ating ACTH daw po and the cortisol level remain elevated after dexamethasone suppression. So, ibig sabihin, hindi siya na-suppress kasi the cortisol level remains elevated and there is a truncal and facial obesity. So, pag mataas ang cortisol, mataas ang ACTH, automatically cancel mo na si Cushing syndrome because Cushing syndrome, pag Cushing syndrome, mataas ang cortisol pero decrease dapat ang ACTH as a part of negative feedback. Pero dito mataas po ang ACTH. So you are left with pituitary tumor. Okay, ito po yun yung Cushing's disease, no? Cushing's disease or pituitary tumor. And then possible din po yung yung ectopic ACTH producing tumor. Okay? So, pareho po dyan na mataas nga ang ACTH, mataas ang cortisol level. But to differentiate the two, we have your dexamethasone suppression. So, sa pituitary tumor, this one will be suppressed. So, kailangan maging normal si cortisol after administering dexamethasone suppression. While for ectopic ACTH producing tumor, it will not be suppressed. So, even after giving dexamethasone, the cortisol levels remain elevated. So, for this case, we have letter C, ectopic ACTH producing tumor. Okay? So we have the 8 ectopic ACTH producing tumor. Okay, next po tayo. Which test is used to distinguish Cushing's disease from Cushing's syndrome caused by adrenal tumors? Okay? So again, one of the tests nga po for us to differentiate primary hypercortisolism from secondary hypercortisolism or your Cushing syndrome or adrenal Cushing from your Cushing's disease or pituitary Cushing is through the use of your ACTH. So we have your adrenocorticotrophic hormone. Because in case nga po of Cushing syndrome, mataas ang cortisol pero mababa ang ACTH. Sa case po ng Cushing's disease, mataas ang cortisol, mataas ang ACTH. Para naman po yung mga other tests na na-mention po sa choices, no? Yung 24-hour urinary free cortisol po, that is the screening test with the greatest sensitivity and specificity because ACTH po and cortisol involves the urinal variation. So sa umaga, no, yun yung greatest amount ng ACTH pero at midnight, no, in the afternoon at midnight, mababa na po ang levels ng cortisol and its lowest value is at midnight, no. Pero if we will use a 24-hour urinary free cortisol, then it will not be affected by the urinal variation. Okay? While the most widely used screening test naman po is the dexamethasone suppression because dexamethasone nga po can suppress cortisol. Pero kapag may case nga po ng Cushing syndrome it will not be suppressed. Ibig sabihin, the cortisol remains elevated. The most specific for establishing diagnosis for Cushing's disease naman po, so for the more specific for diagnostic purposes, we have your petrosal sinus sampling following corticotropin releasing hormone stimulation. Okay? Pag tinanong po tayo, the screen for adrenal cortical hyperfunction with the greatest sensitivity and specificity. So this one is your 24-hour urine-free cortisol as what we've mentioned nga po kanina. Okay. How is primary hypocortisolism or Addison's disease differentiated from secondary hypocortisolism? Again, pag primary, that yung target gland mismo yung problema. Kapag secondary, ang problem ay nasa pituitary gland, in particular the anterior pituitary gland. So dito, how is primary hypocortisolism differentiated from secondary hypocortisolism? Okay, so in this case, kapag yan po ay primary, mababa ang cortisol, no, pero mataas ang ACTH. Kapag secondary naman po 'yon, mababa ang ACTH kaya mababa ang level ng cortisol, no? So in that case, we have letter B, ACTH is elevated in primary and decreased nga po in secondary. Okay, and decreased in secondary. Okay, so again, hypocortisolism is your Addison's disease, primary hypocortisolism. Kung kanina sa hypercortisolism, you have your Cushing syndrome and Cushing's disease, primary, secondary hypercortisolism. Sa case naman po ng primary hypocortisolism, we have your Addison's disease. Okay? Okay. And then also, baka po ma-encounter din natin yung Conn's disease. So si Conn's disease naman po is primary hyperaldosteronism naman po yun. No? That's Conn's disease, C-O-N-N. Okay? Tapos baka din po ma-encounter natin sila pheochromocytoma. Pheochromocytoma naman po is a tumor in the adrenal medulla resulting to overproduction of the catecholamines epinephrine and norepinephrine. Okay? Baka din ma-encounter natin sa endocrinology, Klinefelter syndrome. Yung Klinefelter syndrome naman po is a primary hypogonadism wherein there is decrease in the level of testosterone production. Dahil mababa ang testosterone, there is a case of azoospermia at saka hindi nag-develop ng secondary male sex characteristic yung patient. And then, since a problem po sa Klinefelters is only the gonads, no, primary hypogonadism, as part of the negative feedback, mataas ang FSH at saka LH production. FSH stands for follicular stimulating hormone at saka luteinizing hormone naman yung LH produced by the anterior pituitary gland. Okay? Pag case naman po ng secondary hypogonadism, again, similar approach, mababa ang level ng testosterone kasi nga mababa ang production ng FSH at saka LH. So, yun lang din po, no? Take note lang din natin yung mga different diseases, no? Commonly encountered sa endocrinology. Okay. And then, for estrogen din po pala, pa-take note po ulit yung E1, E2, at saka E3, di ba? E1 or your estrone for postmenopausal women. E2, yung po yung most potent estrogen is the E2. The major estrogen among premenopausal women. And estriol naman po is for estrogen found in maternal urine. Okay. Next, we have here, aldosterone is increased by the adrenal cortex upon stimulation by, so aldosterone nga po is produced by the adrenal cortex, and then this one is upon the stimulation of your angiotensin 2, letter D. Okay, so in your CM, no, kung pwede natin mabalikan si RAAS system or renin angiotensin aldosterone system, 'di ba? Renin It's an enzyme converting your angiotensinogen to angiotensin 1. Then the angiotensin 1 converted by the angiotensin converting enzyme produced by the lungs to angiotensin 2. And angiotensin 2 sa pangalan niya, di ba? Angiotensin. Angio which means blood vessel. So this one is a powerful vasoconstrictor, yung ating angiotensin 2 resulting to increase in blood pressure. Kaya increase ang blood pressure, no? Sa case pag na-activate natin yung renin angiotensin aldosterone system. Likewise, it will also promote the production nga po of the aldosterone, and aldosterone promotes nga po sodium reabsorption. So mataas ang sodium and it will promote potassium excretion, so low potassium. Okay? And then, ayun, it will also increase the production of antidiuretic hormone by the posterior pituitary gland, resulting nga po to water reabsorption, hence increasing the blood volume. So yun po yung na-activate ng renin-angiotensin aldosterone system. So angiotensin 2 will also promote nga po the increase in the aldosterone by the adrenal cortex. Okay? And as we know nga po, again, aldosterone promotes sodium reabsorption and potassium excretion. Next po tayo, tutulid ko na po siya, no? We have here your vitamins, therapeutic drug monitoring, and for toxicology. Okay? So I will just mention yung mga nakikita kong very essential, possible na ma-encounter natin for ASCP examination. So start po tayo. Which of the following substances is the biologically active precursor of a fat-soluble vitamin? So for fat-soluble vitamins, we have your vitamin ADEC, di ba? Vitamin A, vitamin D, vitamin E, and vitamin K. So vitamin A here is your retinol. So we have letter B. Okay. Absorption of vitamin B12 requires the presence of. Okay, so for vitamin B12 or cyanocobalamin, this one nga po for its absorption in the intestine, kailangan nga po dyan ng intrinsic factor. Okay? So we have letter A, intrinsic factor, which is a problem nga po in case of pernicious anemia, because in case of pernicious anemia, there is deficiency of the, or there is an autoantibody attacking the parietal cells. And the parietal cell is the one responsible nga po for producing hydrochloric acid, kinakaroon ng achlorhydria din, at saka ng intrinsic factor. So dahil walang intrinsic factor, there will be a case of vitamin B12 deficiency. And vitamin B12 is important for DNA maturation, hence this one will result to asynchronous development of the red cell or macrocytic, no? Megaloblastic anemia, no? Tapos presence ng mga hypersegmented neutrophil, no? So yun din po yung mga common doon. Okay, for vitamin B12 deficiency. So again, absorption of vitamin B12 requires letter A, the intrinsic factor. So berry is associated with deficiency of vitamin. Is it vitamin A? Is it vitamin C? Again, vitamin A is your retinol, vitamin C is your ascorbic acid, or is it niacin, vitamin B3, or thiamine, vitamin B1? So for berry po, the deficiency is letter, hindi ko pala nalagay, no? So add tayo na lang dito, no? Okay. Kulang dito, hindi ko nalagay si vitamin D. Sorry, ayan, no? So among the given choices, the answer is deficiency in vitamin B1 or thiamine. So deficiency of vitamin B1 or thiamine resulting to berry. Deficiency of vitamin A naman can cause night blindness. Deficiency of vitamin C naman po will result to scurvy, no? Kasi vitamin C is important for collagen synthesis as well, no? So vitamin C deficiency will cause scurvy. Vitamin B3 deficiency naman po or niacin deficiency will cause pellagra. Pellagra is Pellagra. Vitamin D deficiency naman po will cause rickets. No? So again, vitamin B1 deficiency or thiamine, berry. Vitamin A deficiency, we have night blindness. Vitamin C deficiency is causing scurvy because of lack of collagen synthesis nga po. And then vitamin B3 or niacin deficiency naman po will cause pellagra, Pellagra, and vitamin D deficiency will cause rickets. No? Ano po yung vitamin B2? Vitamin B2 is riboflavin. Yung po yung nag-i-impart ng bright yellow color sa ating urine, no? Kapag nag-intake tayo ng mga multivitamins. No? And vitamin B2 deficiency will cause angular stomatitis. No? Nagkakaroon ng mga cracks sa side ng mouth. Okay? Next, for your TDMs, no, the drug procainamide is prescribed to treat cardiac arrhythmia. What biologically active liver metabolite of procainamide is often measured simultaneously? Is it phenobarbital? Is it quinidine? Or is it a cardioactive drug? No? Is it N-acetylprocainamide or lidocaine? So the answer here is N-acetylprocainamide. Okay, so we have N-acetylprocainamide or letter C. Okay, next, an anti-epileptic or anticonvulsant used to control seizure disorders. So we have here your letter E, phenytoin. So digoxin po is for cardiac arrhythmia, for congestive heart failure. Acetaminophen is your paracetamol, which is an anti-inflammatory drug. Lithium or lithium carbonate is for manic depressive disorder or simply bipolar disorder. While theophylline naman po is the one that relaxes the smooth muscles of the bronchial passage. So treatment naman po yan for asthma. Okay, yung theophylline. While for anti-epileptic, anticonvulsant, we have your phenytoin. No? Other examples pa ng mga anti-epileptic or anticonvulsant, we have your phenobarbital. Tapos sa mga petit mal naman, petit mal or absence seizure, we have your etosoximide at saka valproic acid. Okay? So, etosoximide naman po at saka valproic acid. Okay, for petit mal or absence seizure. Okay, active metabolite of amitriptyline. So the answer here is letter A, nortriptyline. So for amitriptyline, we have your nortriptyline. Phenobarbital is a metabolite of, the answer is primidone. So letter A, primidone. Okay, so tandaan po yung mga metabolite questions. No? Metabolite of phenobarbital, we have your primidone. Metabolite of amitriptyline, we have nortriptyline. We have so yun, no? The drug procainamide naman po, metabolite, we have your N-acetylprocainamide. Okay? So yun po yung ating mga questions kanina, no? Next, patient is suspected of having primidone overdose, but the serum concentration is normal. So we test for the metabolite nga po. No? So for primidone, we have your phenobarbital. So we have letter C, test for phenobarbital. Okay? So pag tinanong ulit tayo, phenobarbital is a metabolite of primidone. Okay? So in case of primidone overdose, we can test nga po for the phenobarbital. Next, cocaine. Cocaine is metabolized to, alam niyo po yan, we have letter D, benzoyl-lecgonine. So we have letter D, benzoyl-lecgonine. The metabolite 11-nor-tetrahydrocannabinol can be detected by immunoassay 3 to 5 days after a single use of. So presence nga po of your tetrahydrocannabinol. So is a metabolite of marijuana. So we have letter D, marijuana. Okay. Next. A 3-year-old child was evaluated for abdominal pain and anorexia by a physician. A CBC revealed a hemoglobin of 9.8. So there is low hemoglobin here, possibly may case nga po ng anemia. And there is a presence of basophilic stippling. So there is in particular coarse basophilic stippling. The doctor should order further tests to check for poisoning from. So, pag nakita nga tayo ng basophilic stippling, we have lead poisoning. Coarse basophilic stippling, we have lead poisoning. Zinc protoporphyrin or free erythrocyte protoporphyrin measurement are useful to assess blood concentrations of because lead also affects nga po heme synthesis. No? So instead of iron binding dun sa ating protoporphyrin 9, hindi po makapag-bind si iron doon, no? Dahil doon, tumataas nga po yung free erythrocyte protoporphyrin. So, isabihin, walang iron na present. Or instead of iron, ang pumapalit ay zinc. So, zinc protoporphyrin. So, mataas po yung level ng FEP or free erythrocyte protoporphyrin at saka ZPP or zinc protoporphyrin kapag may case nga po ng lead poisoning. So, lead poisoning. Testing for the diagnosis of lead poisoning should include, so we have dapat po whole blood lead. Okay, so we should test for whole blood lead, no? Whole blood lead. Pero one of its um, um, marker nga po ano, kapag mataas ang zinc protoporphyrin saka free erythrocyte protoporphyrin. But for diagnosis of lead poisoning, so we have letter C, whole blood lead level po dapat. Specimen of choice for immunosuppressive drugs. No? So mga common example po ng mga immunosuppressive drugs, we have your cyclosporine, prednisone, at saka tacrolimus. Pag tinanong po tayo ano ang specimen of choice for cyclosporine, for prednisone, or tacrolimus, which are immunosuppressive drugs, the answer is whole blood. Okay, so whole blood is the specimen of choice. Okay, so again, whole blood is the specimen of choice. Kasi po for drug analysis po, commonly we are using serum. No? But for immunosuppressive drugs such as cyclosporine, prednisone, tacrolimus, we should use whole blood. Okay, so we should use whole blood. Okay, next, a salicylate level is performed to detect toxicity caused by ingestion of excess. So we have acetaminophen po is simply paracetamol, hindi po yan, no? Again, di ba, aspirin, no? So the other name for aspirin is your acetyl salicylic acid. So salicylate level is performed to detect toxicity caused by ingestion of excess aspirin. So we have letter B, aspirin. Okay, so here is the last question for our ASCPI clinical chemistry preparation. Um, to detect barbiturate abuse when analyzing urine specimen, immunoassay is the method of choice for screening. So for screening purpose po, for therapeutic drug monitoring, we are using immunoassay. But for confirmation, alam nyo to, we are using GCMS, tama? Or gas chromatography mass spectrometry. Okay, so yun na po yung ating last item for our ASCP Clinical Chemistry. So sana po makatulong yung ating review as you take for your ASCP I exam. No? Based po sa aking experience before, medyo marami yung lumalabas sa clinical chemistry. Tapos, for micron naman, usually meron po yung mga images na nakasama. So, kailangan po ma-train nyo din po yung sarili nyo sa mga images, especially sa mga fungi. And then, for Hima naman, ganun din yung approach, no? Mas higher level dapat, more of application type. Wag po tayo mag-aral ng parang board like, no? So more of application type like what will the MLS do, ano yung mga common na error, no? So yun po yung kailangan yung tignan, no? Yung mga false positive, false negative, no? So yun po yung mga mas essential. And then syempre yung mga reference values po, useful po yan, no? To guide you in analyzing yung case. Okay? And then pinakamahirap po para sa akin na subject would be blood bank. Yung po yung mas may challenge sa ASCP. No? So if gagawa po kayo ng schedule, advice ko po na start with blood bank, and with blood bank, no? Sa pagre-review for your ASCPI preparation. And then, ayun, so don't forget din po yung mga essentials, no? Like for clinical chemistry, no? For HEMA, no? For micro, ayan. Buti na lang po walang histopath, no? For the ASCPI preparation. Okay. So again, for clinical chemistry nga po, advice ko na reading material or study material aside from our Lemar notes is your BOC questions. Pero majority po ng mga question that I showed here is from BOC. Tapos, Polanski po, no? As a, kumbaga, summarized way of recalling clinical chemistry. No? Maganda po yung po landscape for ASCPI preparation. Okay? Tapos if meron po kayong Lab CE, useful din po siya to practice. And there are mga similar questions din, no, na pwede niyong ma-encounter sa Lab CE. No? So, kung meron po kayong account, no, kung meron kayong na-purchase, then utilize nyo na lang po, no, for the Lab CE. Okay, so again, thank you po, no, for listening, no, dun sa ating pong lecture series for clinical chemistry. So we are continuously praying po, no, for the safety of everyone. And ayun, no, and after this crisis, no, we may continue to pursue, no, yung ating pong career, and we are praying po for everyone's success, no. And may this exam, no, be a big leap, no, for everyone. So yun po. And most importantly po, ayun, syempre, um, let's enjoy studying din. Kasi yun din po yung mas na-enjoy ko sa ASCP noon. No? Even though mas challenging yung mga type ng question, mas na-enjoy ko yung exam. No? And of course, no, we trust God in His ways. No? Um, and always, basta we do what we can do, no? We prepare what we can prepare, no? And He will do the rest. No? We just need to lay everything to Him. No? So again, we pray po for everyone's success, no, in taking the ASCPI exam.